Hello friends, today we'll be discussing deep vein thrombosis. So before starting, I would like to thank Chandana Shri Ma'am for sharing the wonderful notes with us, and these notes are very helpful for quick revision for all MBBS, MD and DNB exam, MS exam. So the notes link for the notes is given in the description below. You can download it from there. So without any further delay, let's get started. Deep vein thrombosis. So deep vein thrombosis is basically formation of intraluminal coagulum blood clot within the deep venous system. So what is the pathophysiology? Is due to virtue of stride, as we know, thrombosis, due to stasis of the blood flow, endothelial damage, which is generally seen in the secondary or provoked DVT, or hypercoagulability, which is the third part, which is commonly seen in the spontaneous or unprovoked DVT. So convergence of several risk factors in the background of imbalance between coagulation and fibrinolysis. So there is imbalance between coagulation and fibrinolysis. Normally these are very balanced and prevent coagulation of the blood in the venous system. But if there is imbalance, then it will result in coagulation and clotting of venous thrombosis. So balance between recanalization of venous lumen and recurrent thrombotic event. It is the important determinant of long-term outcome after an episode of DVT. So the balance of recanalization and recurrent thrombotic event. So it normally happens that it will be taken care of, but if this balance is disturbed, then there will be long-term outcome in the form of syndromes, thrombotic syndromes. So what are the risk factors for venous thromboembolism? Is again virtuous triad, stasis, that is contributing to the endothelial cell layer coming in contact with the activated platelets and procoagulant factors. So platelet and procoagulant factors will come in the contact with the endothelial layer and will cause stasis. And contributing observation that soleal sinuses are the most common site for initiation of the DVT. So the foot, the leg soleal sinuses, soleal muscle sinuses are most common site for initiation of DVT. Then we have hypercoagulable state and venous injury. So hypercoagulable states could be due to congenital and acquired causes. Congenital will be factor 5 Leiden mutation, antithrombin deficiency, protein C, protein S deficiency, factor 11 elevation, dysfibrogenemia. Acquired will be malignancy, pregnancy, purpurium, nephrotic syndrome, APLA, myeloproliferative disease, polycythemia, hormone replacement, OCP use, mixed in the form of homocystinemia, hyperfibrogenemia, factor 7, 8, 9, 11, if these are increased. So these are all the causes of hypercoagulable state. Now stasis, which could be due to any major surgery, prolonged hospitalization or immobilization, long air travel, spinal cord injury, endothelial injury in the form of trauma, central venous catheterization or surgery, anatomic factors like May-Turner syndrome, which causes compression of the left iliac vein where it is crossed by the right iliac artery. Various scoring system to predict venous thromboembolism risk, that is Rogers and Caprini. Pathophysiology, occlusive thrombus will cause platelet aggregation with fibrin or RBC will form the thrombus, which will propagate proximally and both distally. Obstruction of the venous outflow will result in the edema and pain over 24 to 36 hours when there is subsequent sufficient outflow obstruction, and later it will cause recanalization and collateral venous outflow. Now we see some syndromes of this DVT, that is phlegmasia cerulear dolens, where there will be extensive DVT of the major axial deep venous system with relative sparing of the collateral veins. So in cerulear dolens, there will be sparing of the collateral veins. It will cause pain, pitting edema and cyanotic congestion. In phlegmasia alba dolens, it will cause thrombosis, including extending into the collateral veins, resulting in massive fluid accumulation and significant edema. So it will be extremely painful and edematous, and here it will be pale due to arterial insufficiency, and there will be compartment syndrome. Later, both can present, that is phlegmasia cerulear dolens and AKBAR dolens will progress to venous gangrene and will need amputation. Now we will see the complication. In complication, the most dreaded, which is the pulmonary embolism, where 50% in patient presenting with symptomatic DVT, around 50 to 80% will have asymptomatic pulmonary embolism. So if the patient is having symptomatic DVT, most of them will be having asymptomatic pulmonary embolism, and patients with symptomatic pulmonary embolism, most, that is 80%, will have asymptomatic DVT. So it is very interrelated. Then we have and this symptomatic pulmonary embolism will be in the form of pulmonary hypertension. Now, post-thrombotic syndrome, which is the late complication seen in around 20 to 50% patient with DVT, it is a consequence of venous hypertension due to luminal obstruction and valvular reflux. Severity is increased when iliofemoral segment is involved. It will cause chronic edema, pain, venous claudication, varicose vein, and venous ulcers. Now we see the clinical features. So first and foremost, it will need a high index of clinical suspicion, and only 40% of DVT will have obvious clinical signs. So other signs like fever, painful edema, that is phlegmasia cerulear dolens or AKBAR dolens, Homan signs, that is calf pain on plantar dorsiflexion, or Moses sign, that is calf tenderness. So this was about clinical features. Now we see the evaluation, that is first commonly used is a duplex ultrasound, which is the best initial test, which is accurate also and non-invasive, which will give us the details of the anatomic distribution of the thrombosed veins, degree of occlusion, collaterals, recanalization, echogenicity, compressibility, proximal extension, and also easily can be used for follow-up. Disadvantages will be that the case this technique is observer dependent, poor information regarding iliac and IVC. Then we have venography, which is most accurate but is not commonly used. It is done when some intervention is planned. It could be ascending or descending. Ascending venography, where the peripheral vein is cannulated, tourniquet is applied to prevent the entry of dye to the superficial system, and contrast is injected with bolus tracking, and we visualize under fluoroscopy. Then luminal filling defect surrounding with a rim of contrast, that is the tram track sign, which will help us in giving the picture, and abrupt termination of intravascular contrast, that is meniscus formation. This will give us the picture of DVT. And ascending venography, which is commonly done for the DVT or perforatory incompetence, venous aneurysm, and malformation, whereas descending venography is done for valve reflux and in the superficial and deep veins. Then we have less invasive method, that is MR venography. It can directly image the thrombus, so we will not also need any contrast. Will not need any contrast. Impedance plethysmography measures change in venous capacitance and rate of emptying of venous volume on temporary occlusion. So next is the D dimer, which is a marker for DVT, and it is product of fibrin proteolysis by plasmin, and it is increases in case of fibrinolysis of the complex fibrin. So D-dimer, it is a cross-link degradation product of fibrin proteolysis, and in combination with clinical evaluation, its sensitivity is very high, more than 90 to 95%. But it is not always associated with DVT. Sometimes it is elevated in case of post-surgery. So negative predictive value is 97 to 99%. So negative test effectively will rule out DVT. Iodine 125 fibrinogen uptake test, that is more than 20% increase in one area of the limb will result in DVT, is a sign of DVT. So this was all about diagnosis of DVT. Sorry for the delay. I would like to add on to the discussion, that is the modified Wells criteria for predicting DVT, which is given in Bailey in a form of a table. So here we have various aspects, variables which are added to predict DVT. So first is the lower limb trauma or surgery or immobilization in plaster cast, which will give 1 point. Bedridden for more than 3 days or surgery in last 1 week, that will add 1 point. Tenderness along the line of femoral or popliteal vessels, veins, that will add 1 point. Entire limb is swollen, that will give 1 point. Calf more than 3 centimeter larger circumference than the other side, 10 centimeter below the tibial tuberosity. So 3 centimeter below the 10 centimeter below the tibial tuberosity. If the circumference difference than the other side is more than 3 centimeter, it will add 1 point. Pitting edema, swollen and pitting edema almost similar, but it will add pitting. Dilated collateral superficial veins, that will add 1 point. And it is not varicose vein. Then previous history of DVT, malignancy, which is including treatment up to 6 months ago. Then IV drug abuse. IV drug abuse will add more number of points, 3 points, rest all is 1 point. Then alternative diagnosis more likely other than DVT, it will add minus 2 points. So this will make a point that it is negative, the last one. If other diagnosis is more likely, then it will be minus 2. So it is total of around 5 here, 4, 9, 9 plus 3, 12. Maximum is 12 and minimum could be even minus 2. So probability of DVT will be 5% if the score is minus 2 to 0. Moderate if the score is 1 or 2, that is 17%, and high probability 70 to 50% if it is more than 2. Similarly, we have a modified Wells criteria for pulmonary embolism, which is a very dreaded risk complication of venous thromboembolism. So clinical signs and symptom of DVT will give score of 3. Alternative diagnosis less likely than pulmonary embolism, again 3. Heart rate more than 100, 1.5. Immobilization 1.5. Previous DVT or pulmonary embolism 1.5. Hemoptysis 1. Malignancy, treatment or palliation within 6 months, that is again 1. Score less than 3, pulmonary embolism is unlikely, 12.4%. If it is more than 4, it is suggestive of pulmonary embolism with 40% chances. The maximum score here again will be around 9, 10, 12.5 maximum. So more than 4 is highly suggestive of pulmonary embolism. Then we see the risk groups for venous thromboembolism. So low, medium and high. If there is surgery in a minor surgery less than 30 minutes with any age and no risk factors. Major surgery is more than 30 minutes, age less than 40, no risk factors, and minor trauma or medical illness. So these will all account for low risk patient group for venous thromboembolism. Medium risk, that will be major surgery, age more than 40 or other risk factors, major medical illness like heart, lung disease, cancer or inflammatory bowel disease, major trauma or burns, minor surgery, trauma, medical illness with previous DVT, pulmonary embolism or thrombophilia. These will constitute medium risk. And high risk, major orthopedic surgery or fracture of pelvis, lower limb, hip, major abdominal pelvic surgery for cancer, major surgery, trauma, medical illness in patients with DVT, pulmonary embolism or thrombophilia, lower limb paralysis, stroke or due to stroke or paraplegia, major lower limb amputation. So we have to consider the high risk patients specially. So either orthopedic surgery of hip, pelvis, lower limb, abdominal surgery for cancer, pelvic surgery for cancer. These are some. Major surgery in a patient who has a previous history of DVT or pulmonary embolism, lower limb paralysis, or major lower limb amputation. So these all will constitute high risk patients. So now we will be seeing the management part of thromboembolism. So management is to mitigate mortality and morbidity associated with pulmonary embolism and post-thrombotic syndrome. So we have to prevent pulmonary embolism and post-thrombotic syndrome as much as possible. So initially we'll go for anti-thrombotic therapy, which is the first point, and the goal will be INR to be maintained between 2 and 3. Here we'll start with vitamin heparin with vitamin K antagonist combo, that is unfractionated heparin, low molecular weight heparin or fondaparinux. It has to be started and is to be continued for minimum 5 days. Then we have to continue with warfarin, dicomarol or nicomalone. So how does unfractionated heparin works? It binds to antithrombin and inhibits factor 2A and 10A. Along with that, it also inhibits tissue factor. Antithrombin is independent of inhibition of thrombin via heparin cofactor 2. So how is the dose? That is 80 international unit per kg, that is bolus, followed by 18 international unit per kg per hour in infusion. Low molecular weight heparin is given around and it inhibits factor 10A. 0.6 for treatment, 0.6 milligram subcutaneous. And unfractionated heparin we generally give 5000 initially, followed by 2500. Then direct thrombin inhibitor, that is parenteral, which is recombinant hirudin, agatroban or B-valirubin, oral which is dabigatran, and the antidote for dabigatran is idarucizumab. Direct 10A inhibitors, that is apixaban, rivaroxaban and edoxaban. Duration of action here is minimum 3 minutes and may be extended if second episode of unprovoked or cancer related case is there. This is for direct thrombin inhibitor. Then we go for thrombolysis. So it is catheter directed rather than systemic and useful for extensive iliofemoral DVT. So it is high DVTs in case of iliofemoral. Here we use streptokinase, urokinase, altiplase, retiplase or tenecteplase, and may be used in the form of pharmacomechanical thrombolysis. So we use the mechanical therapy also along with it. Here plasminogen thrombolytic will form plasmin and fibrin degradation and clot lysis. So plasminogen will form plasmin, fibrin degradation and clot lysis with the help of thrombolytics. Then next is IVC filter. It is for the lower limb DVT where there is absolute contraindication of anticoagulation. We cannot give antithrombotics. Severe bleeding due to anticoagulation therapy, recurrent DVT despite adequate anticoagulation, or patient with severe pulmonary hypertension. So these are the 4 points which you have to consider for IVC filters. Then complication. So at the site of bleeding, at the site of insertion, thrombosis, blockage, breaking, migration, erosion through IVC. So it is recommended to remove it once the roll is complete after 30 to 60 days. Then venous thrombectomy, it is reserved for acute iliofemoral DVT where patient worsens even after anticoagulation therapy. Phlegmasia cerulean dolens with impending venous gangrene, despite fasciotomy, they will also need venous thrombectomy. So operative venous thrombectomy with or without intravenous angioplasty or plus or minus stenting. AV fistula formation between GSV and superficial femoral artery to maintain iliofemoral patency, and pulmonary embolectomy for pulmonary thromboembolism. So this was about venous thrombectomy and overall about management of DVT. So hope you have understood. Thank you for watching. Please like, share and subscribe. Keep studying, keep growing and never give up. See you in next video. Thank you.